So I think this is a good way to sort of sum up where we need to be going in the field. We've already gone through quite a few aspects of bipolar disorder. We know it's low prevalence, but we know it's also a leading cause of disability. In the early stages, even though there can be symptom recovery, functional recovery can be delayed, and there may not be functional recovery. We know rates of suicide are high and death occurs 10 to 20 years behind. One factor I find is really interesting in this study, that the healthcare costs for bipolar disorder are higher than for depression, asthma, or cardiovascular disease. So why the burden? And there's lots of factors and some have already been described today. So we're still trying to work out the pathophysiology and the underlying mechanisms. I think one of the biggest areas, and this is why we need early intervention in bipolar disorder, is that diagnosis and most recent estimates is still delayed by 9, 10 or more years. So the recent estimate was 9.5 years from original onset of symptoms to getting a diagnosis, and it still may be delayed getting appropriate treatment. It's still difficult to work out who is going to develop bipolar disorder. And we need to be looking at, and Phil's been highlighting the work of differentiating unipolar and bipolar depression. But as we lack assessment tools in bipolar disorder, as well as in psychiatry. We need a revamp. That's a whole other story. And we know that comorbidity is a norm, so including anxiety disorders. Treatments. There's a lot about treatments and we're still working things out. Often there can be harmful treatments. We really haven't had new treatment discoveries since lithium. Also, I suppose polypharmacy is a norm, and what are the implications of that? The consequences of medication side effects, and psychotherapies. And this is an area that we've been working on at Origin and leading a psychotherapy trial to improve functional outcomes in young people, is that these interventions are scarce, they're difficult to access, and not many clinicians are trained in them. The other big area, and this is why we're plugging early intervention for bipolar disorder, is that most interventions are actually developed for chronic populations. Michael has talked about a lithium contyping study. That was probably one of the first in the early stages of bipolar disorder in young people, but we need more work in this area. So, as I said, we have got lots and lots of work to do. So another area is that we often work in silos. And I think the early psychosis world has been great in bringing people together. And we're only just starting to do that in bipolar disorder, but we need those initiatives. Another big area is that we need to think about capacity building. So it's very hard to get clinicians trained in bipolar disorder. How do we train our next group of clinical researchers to be focusing on this disorder? And as I said, we need to often think about how do we go about this work? And we're trying to start, okay, there's lots of research in more chronic and established disorder. What can we do about early intervention and how can we go about it? And we've been developing some initiatives around that. And one of the initiatives is around working with the Daymark Foundation in Canada. And we've recently brought experts all over the world who are working with at-risk and early stages of bipolar disorder and trying to get early intervention on the agenda. But at the same time, we established and were successful in obtaining a Centre of Research Excellence funded by NHMRC to work on bipolar disorder. So we called it for the Centre of Research Excellence in Bipolar Disorder, and I think Core BD is a fantastic name. We always have to come up with acronyms for our studies. So the focus of Core BD is basically developing a better understanding of the early stages of disorder, including, and here we're looking at risk and early stages of disorder. We also want to improve our interventions and build our evidence base particularly for the early stages of the illness and also for young people. We've got a big investigatory team, but this is not only the key investigators. We've got a whole range of other investigators, and we were fortunate to bring the field together for our first kickoff meeting. And it's so great post-COVID to be able to bring everyone together and meet in person. So we had our kickoff meeting in last month, and I'm going to go through what we're looking at. So I think a big issue in psychiatry and getting research in mental health established is looking at how can we get our research and implemented into more quickly. So the premise underlying Core BD is to have a translation framework ranging from how can we use multiple disciplines ranging from basic science through to epidemiology to looking at developing and testing new interventions, strengthening our evidence base, involving, the most importantly, communities and those experts by lived experience in the process, and supporting organisations, and how can we improve outcomes at a population. So it's quite a different approach to just say, let's just get our research done. We need to put it into context. So our two themes we have broken down in terms of Core BD, basically to develop the understanding. So what data can we use to look at better understanding opportunities for early intervention? And also, how can we get best out of interventions for at-risk and early stages of disorder? So there is so many questions that we could ask, but these are an array of questions that were put in the grant. But we want to look at factors discriminating between individuals at risk with other psychiatric comorbidities. So the transdiagnostic field is a growing field at the moment about at-risk states for multiple early stages of depression, anxiety being risk for multiple disorders. But how can we look at it in terms of bipolar disorder? And building on Phil's work, how can we look at differentiating unipolar from bipolar depression? We would be particularly interested in looking at are there any such differences in youth populations? What factors can predict onset? And also a big area that we're leading at Origin at the moment is looking at data linkage. Can we identify missed opportunities for diagnosis and care through data linkage? So we found with our Recover psychological therapy, young people are not getting to services with bipolar disorder. So where are they going in the community? And I think particularly bipolar 2, we don't know where they're going. Are they presenting to emergency departments, but are they presenting with substance use issues? And are the substance use issues being means that bipolar has been overlooked? We also want to look at best out of interventions. So what are our novel treatment targets? Michael and Ken Walder are leading drug repurposing techniques and looking for new treatment targets. How can we look at epidemiological data? And also through data linkage, we'll be looking at factors such as lithium use. How can we use the staging models to understand which treatments should be implemented when? And what are the benefits of blended intervention? So Ashwin Rathish, who's a consultant psychiatrist at Origin, has recently secured a partnership grant to be looking at a blended intervention for young people with bipolar disorder. And I think importantly, to highlight the importance of this work, we need the health economic impacts of bipolar disorder and what our work can do to minimise that. As I mentioned, a big focus of the Centre of Research Excellence will be enhancing the workforce. So we're going to be looking at ways to improve research training, attract new talent to the field. Also, a range of other activities will be used to build capacity. And through this work, we have a capacity building model, looking at what strategies we're looking at, what research skills, what sort of outputs and what sort of impacts. Again, it's a very much translational focus. I mentioned also about key stakeholders. So rather than just looking at academic networks, we're looking at broader. We're looking at the importance of lived experience or experts by experience, looking at community groups, the media. So we've got ABC reporter involved on our translational committee, a science medical reporter. Clinical input. I think if we want to implement our treatments into clinics, we need to know whether it's appropriate and clinicians are resourced to be able to do that implementation. Also, we're looking at advocacy as well as policy and also academic translation. So we've got colleagues such as Andy Nuremberg and Jan Scott who are also contributing to this work. This is just highlighting the networks that we bring to Core BD. And there's much more work that's being done in this space, including with the new initiative through the Daymark Foundation. So deliverables. When we look at what we write and put in the grant, we've actually got lots of work to do. And we're still setting priorities, and we're actually only 2 months into the centre. So we have got lots of deliverables. I think one of the big areas around psychoeducation is that there's not really a lot of literature to help young people and their families around bipolar disorder and what are the impacts. We've also been doing a bit of work around the impacts on siblings without the disorder and what supports they need. We need to be looking at bigger picture, how can we get refinement and harmonisation of our tools? As mentioned previously, a lot of our tools are not necessarily capturing what we should be. So what is meaningful for individuals with a lived experience? What does functioning mean? What is meaningful about functioning? How do we better capture that experience? Measures of depression, that's another area that we need work on. So a lot of our traditional measures of depression are probably outdated and don't actually look at the atypical features of depression. And when we actually do get a client to fill out a measure of depression, we often just look at total scores, but that is becoming increasingly not relevant. We need to be actually looking at profiles across the individual symptoms. We need data harmonisation, and it's basically capturing who's got what and what has been collected. Ideally, there's been lots of initiatives around developing data clinical trial networks, including the new Magnet initiative. How can we build up resources to support a bipolar network? And I think this is really important because it's really difficult to do a single site study. We need to be looking at increasing our capacity. We need proper assessment of our interventions. We need to look at other collaborations, and this work that we've been doing with the Daymark Foundation, we've just released a report last month where we interviewed experts all over the world, and we came together in a meeting in Lausanne in July, and we have identified 9 themes where we need to advance early intervention in bipolar disorder, including things like data networks, right through to how do we actually develop clinical models for the disorder. And from this one-day meeting, we've actually come up with 6 projects. And there's a collaboration going across the 6 projects. Now we're starting to meet with other philanthropic organisations to see how we can fund and progress this work. So one of the ideas is around having, for example, lithium clinics. So similar to the clozapine clinics, providing more support for clinicians, GPs in prescribing lithium. Because there's growing evidence that clinicians are fearful of making a diagnosis of bipolar disorder, are fearful of using lithium, and that's why partly we're seeing a decline in lithium use. But we also need to develop further evidence. As Michael said, we've got some evidence in young people that lithium works, but the longer term effects. So there's a lot of work that we're doing around that, and I'm happy to circulate the report that we've developed for the Daymark Foundation. And if people are interested, there's a lot of working groups that are now being formed. We're looking at developing web-based educational resources, and this also is going to be helpful for working towards the early stages of the disorder, but also working with organisations such as Bipolar Australia and other leading organisations. We need to upskill clinicians and health services. This is a big issue that we have identified through our work with the Daymark Foundation. Clinicians are fearful of diagnosing bipolar disorder. They're not recognising the signs and symptoms, even including in early psychosis services. Mixed episodes, particularly prevalent in young people with a disorder, are not being picked up. So the young people are potentially getting harmful treatments. So we need to raise awareness around our clinicians and health services and also GPs. We need to raise broader community awareness, and also, as I said, highlighting developing a better and more integrated early and mid-career research group to advance this work. So in conclusion, I suppose I was going to say for the core BD, we'll first time create a critical mass, but I realised that, work with Daymark that we're already establishing a critical mass, but I think core BD gives us the opportunities to advance the field of bipolar disorder, especially in the early stages. And I think we're already developing collaborations and networks that we can really extend this work. And rather than being 15 to 20 years behind in terms of our work in the early stages of disorder compared to the early stages of psychosis, having the collaborative networks is going to be so important to building this working area. So thank you.